Hi, Sharon.
Hello.
Good afternoon. Good to see you. It's been a minute
Been a while.
since we've had our last
Yeah, the last
first.
one I think was at the conference we were at.
Yes, but as for those of you who've tuned in today and are aware that this is a breast cancer Q&A webinar, a series that Sharon and I have been doing to address common questions about breast cancer and its treatment. Um, I'm a breast cancer surgeon, Dennis Holmes, and I'm joined by Sharon. Would you introduce yourself?
Yeah, I'm Sharon Merritt. I am an Alamo Scholar from 2024.
Here.
I'm a Susan Komen Science Advocate, and I guess that's all, I think.
And so much more, but
Yeah, I
you,
get involved in a lot of different things. I'm on I can't say too much, but it's a congressional thing right now, so.
well, thank you. Well, and she has been, patient advocate who has kind of mediated this webinar by, reaching out to peers who have questions about breast cancer, collecting those questions. And we've had a series of webinars covering various topics. They're all available online. This one will be available on YouTube, perhaps later this weekend, but soon. But the purpose is really to give individuals the opportunity to ask questions about various breast cancer topics, each webinar generally focused on a particular topic. And today's webinar is focused on,
Men's breast cancer.
okay,
Because one of the interests, I met a lady at Costco not a couple months ago, and her husband died at the age of 57 because by the time they found out he had breast cancer, it had metastasized everywhere.
mhm.
So that kind of prompted me that people don't know enough about it. And then I've been doing physical therapy, and I mentioned to my physical therapist I was going to do this webinar on men's breast cancer, and she goes, "Oh, I didn't know men could get breast cancer."
Mm.
So obviously, there's a lot of people that don't realize it can happen, and that's not a good thing.
That's not a good thing. But after this webinar, hopefully a lot more will realize it. Either they'll learn today or they'll see the
They'll
webinar
see that,
later
yeah.
and we'll be able to kind of expand their knowledge base about
And I have
breast cancer.
met a few men too that had it. When I went to the LBBC, Living
Yes.
Beyond Breast Cancer, there was a man there that had had breast cancer.
Mhm.
And then I've had a couple of them actually text me through Facebook. So,
Oh, great, great. Well,
yeah.
thanks again for your leadership uh, and advocacy.
So should we get into the questions?
We can get started.
What is being done to address men's breast cancer, and what percentage of diagnosed breast cancers are currently in men?
Well, that's a two-part question, and the first part is what is being done? This is being
Yep.
done. Obviously, there are organizations, and you'll hear about one later today that is focused on this particular question, increasing awareness about male breast cancer. But it's as you have appreciated it, although it's a definite thing, it's such an uncommon thing that much of the attention about breast cancer is focused on women and not men, given the infrequency. But if you think of the statistics for women, about 1 in 8 will develop breast cancer in her lifetime. For men, it's about 1 in 700.
Wow.
So that's about less than 1% of men who will be diagnosed with breast cancer. You think of the people who are diagnosed with breast cancer, less than 1% of them will be male. So it's an uncommon event, but of course, there are a lot of men in the world. And
Yep.
if it's few, and there are a lot of breast cancers that are diagnosed each year. So even if it's less than 1%, that adds up to a number of men. And so for 2025, it's projected that about 2,500 men will be diagnosed. I think that's the number, diagnosed with breast cancer. And about 500 or so of them would die of breast cancer because of, later
They
stage
didn't know.
diagnosis. Right.
They wait too long.
So those are the basic statistics. So it's uncommon, but common enough that people should know about it, should anticipate it as a possible diagnosis if they have certain symptoms. And there's also some things you can do to kind of preempt,
Mhm.
be proactive, and we'll talk about that.
In your opinion, what could medical professionals be doing to help raise awareness in men and their potential risk for being diagnosed with breast cancer? I will say my husband found a lump years ago and he went and had a mammogram. Turned out to be not anything, but still, you got to check.
Well, I think you have a question about sort of breast lumps in general, a term called gynecomastia, which we'll talk about, I think, a
Yeah.
little bit later. But the main thing that providers need to do is just communicate to men that breast self-examination is a part of their normal self-examination. Obviously, talk about women
Right.
breast self-examination. It's so much easier to examine a male breast.
It's not a whole lot
There's
better.
not there for most men. For most men, so just increasing awareness about what normal breast anatomy looks like. Even just examining under the areola can reveal some findings that they might not be aware of if they don't look. And since we don't do routine screening, and we can talk about that, there's no other way for
Right.
it to be found.
And my guess is they can get Paget's too. If they can
They
get
can
breast
get
cancer, they can get
all the
Paget.
same things, and we'll talk about that. But back to the provider. So one is awareness. Men can get breast cancer, starting there. Number two, breast self-examination or examination is the main way that breast cancer is diagnosed in men. And they should do breast exam. Even if they're just showering, they should be at least be aware of the texture and anatomy of their
Right.
breasts. Um, and then, but the other thing that is similarly impactful, and this is going to hit upon a number of potential questions that we have, is there are some male conditions like prostate cancer that are linked to breast cancer
Okay,
risk.
that makes
I'll
sense.
explain why. And so, if you have a relative or a patient who has a high grade or advanced stage prostate cancer, then they should undergo genetic testing for a breast cancer mutation because they run together.
Well, that's kind of, with women, it's breast cancer and uterine cancer.
Right. I mean, there are a number of genes, like BRCA1 is predominantly breast and uterine, but BRCA2 includes breast, uterine, and male breast cancer, as well as some other cancers. And so a huge missed opportunity that I see is that men are being treated for prostate cancer. No one, and some with advanced prostate, and no one has ever asked them, have you had genetic testing? Because if you are a mutation carrier, and if that mutation gave rise to your breast cancer, then that mutation could run in your
Or to
family.
that prostate cancer.
I meant to say prostate cancer. That mutation can run in your family and also can increase your daughter's risk or your
Right.
siblings' risk of having. So you have to kind of connect the dots and asking about genetic testing for prostate cancer, not just for breast cancer, is important.
Well, I think
But
maybe physicians should have a pamphlet or something in their office, like they have all this other stuff saying that there's men's breast cancer and that you should check yourself.
that's a good idea.
Yeah, I think the organization that's gonna pop in later, I think they actually have a card with things to check. I've heard nearly all breast cancer in men is estrogen receptor positive, with treatment including hormonal therapy, just as in 70% of female breast cancers. Is this true? And if not, or if it is, what type of breast cancer do men usually get?
Okay, so a number of questions in that one. So that we'll start at a very high level. So we normally think of breast cancer it's divided into sort of invasive breast cancer and non-invasive breast cancer, like invasive breast cancer and DCS, the two basic categories. Um, Invasive breast cancer is for men is most commonly an invasive ductal cancer. Uh, about 98% of them are invasive ductal cancer, as opposed to, say, 90% of women. Conversely, about 2% of them are invasive lobular breast cancer, whereas in women, maybe up to 10% are invasive lobular breast cancer. There's some biological reasons for that. Uh, but that's the first category. Now, although about 25% of breast cancers are non-invasive when diagnosed in women, like D says.
Mhm.
Only about maybe 5 to 7% of breast cancers are diagnosed as DCS in men
Because they don't look for it soon enough.
because they're not being screened. DCS is primarily a diagnosis of screening. I mean, you can make the diagnosis at such an early stage because you get screened. And since men don't get routine screening, they aren't usually diagnosed with in DCS. Although they can have certain symptoms that can lead to a workup and a diagnosis.
DCIS is the easiest one to take care of.
It's curable when treated. So that's the first kind of level of the question. Most of it's invasive, very few are non-invasive or DCS, and most are invasive ductal carcinoma, relatively few are invasive lobular carcinoma. Now, the other question related to receptor status. In many ways, male breast cancer is like female breast cancer in that it's predominantly estrogen receptor positive. Some may be HER2 positive, some may be triple negative. There are fewer triple negatives and HER2 positives. Most of them are hormone receptor positive. And because most are hormone receptor positive, like 70 to 80% of them or more, then the primary mode of treatment is to use an anti-estrogen therapy just as it is for female breast cancer.
What are the factors that increase a man's risk of breast cancer?
So that's an interesting question. And so there's several categories of risk factors. Um, some of them have things in common, but the fundamental problem that's common to many of them is that they have a relatively high level of estrogen compared to their testosterone. They still have testosterone, but the balance between testosterone and estrogen, it can be shifted in favor of there being too much estrogen, and that can cause overstimulation of the milk ducts, and that ultimately can lead to cancer. So conditions where that is common. Um, One condition could be liver disease because people with chronic liver disease
Fatty
don't,
liver.
yes, they don't process estrogen, they don't degrade estrogen efficiently, and so they have a higher estrogen level, and their breast can see that, and that can stimulate a cancer formation. We have people who take steroids, like anabolic steroids, like for muscle building, might build their muscles, but when you take a lot of testosterone, the body converts some of that to estrogen. And then their breasts see the estrogen and they can get stimulation. We have men who have, say, prostate cancer. I mentioned that earlier.
Mhm.
When they take medications for prostate cancer, it blocks their testosterone. So they have more estrogen to testosterone. So that increases their risk. We have, we already mentioned the example of a BRCA1 or BRCA2 mutation. Both can be associated with breast cancer, although BRCA2 is more commonly associated with breast cancer, but there are other mutations as well that can be. And then a couple other factors I want to mention. One is obesity, like having a lot of extra body fat. Fat makes estrogen, just it makes estrogen in women, just like it makes estrogen in men. And because they have more estrogen on board, there is more fat stimulation or breast stimulation in those. I think those are the main ones I would mention for now, without getting too much more into the weeds.
What are the most common symptoms for male breast cancer?
Well, in many ways, the symptoms can be identical to what you see in female breast cancer. They can present with a lump. Obviously, we're kind of taking out the categories of people who have screening because they generally don't have screening. So the diagnosis is usually symptom based. It presents because it's a symptom, and the most common symptom that they perceive is a lump under one breast.
What about the size of the breast? Some men actually look,
Have like
yeah,
look like
almost have
women,
breast.
look like
Almost,
women
yeah.
in terms of their breasts.
Not totally, but sort of.
Yeah, uh, so
Does
what
that
you're
make them more likely to get it?
so what you're referencing is gynecomastia, but gynecomastia, and we'll talk about that more in a moment, but gynecomastia, it can be the first physical response to having a high level of estrogen. And so it affects both breasts. But then the underlying problem, the thing that's increasing the estrogen, can be the thing that causes one of the breasts, not likely both, but one of the breasts to develop a breast cancer. So they run hand in hand. Gynecomastia doesn't cause breast cancer, but the condition that causes gynecomastia can cause breast cancer.
Are there
But there are a few other symptoms. I'm sorry.
That's
So lump being the most common one. They can have nipple retraction
okay.
because the lump is often near the nipple and it pulls in the nipple. They can have nipple discharge because the ducts leading to the nipple can leak clear fluid or bloody fluid. Either one can be present. Um, they can have Paget's disease, where
Which a lot of doctors confuse with eczema.
right, and I've
It's
seen
dry as hair.
patients and treated patients with that condition, male patients, where they had a nipple rash that became an areolar rash, and they assumed it was eczema, but it was actually, the process of the breast cancer growing up the milk ducts onto the surface of the skin and into the skin and causing changes there. But that can be a symptom. Uh, male breast lumps are usually non-tender, just like female breast lumps that are cancerous, but they also may be painful. And then, of course, sometimes people present with more advanced disease. They feel a lump in the armpit, for example, that is an indication of spread. Those are the most common symptoms one would see.
Are there tests that assess men's risk similar to how a mammogram assesses women? A
Well,
mammogram, right?
a mammogram, a mammogram. So there's no screening test. Given the infrequency, 1 out of 700 men, it just isn't a prevalent enough disease to routinely screen everyone. Unless, even men in high risk families aren't routinely screened. Uh, Certainly they should examine themselves, but there's no like screening mammogram or screening ultrasound protocol. But for men who develop lumps in the breast, uh, it is customary to recommend that they get a diagnostic mammogram
Mhm.
done to look at the breast anatomy. In some ways, and in many ways, a mammogram in men can be diagnostic. I previously talked about gynecomastia, and I talked about breast cancer. Gynecomastia is a benign condition. And when you do a mammogram of a breast that has gynecomastia, it demonstrates, they call it like a flame shape, almost like a triangular shape pattern to the glandular tissue. It's almost diagnostic. Like when you see that,
It's cancer.
no, 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 no,
Oh, it's
no,
not
no,
cancer.
no. This
Oh,
flame
okay.
shape pattern is benign.
Oh,
Like
okay.
like once you if you have a man with gynecomastia, and all you see is this flame shaped pattern of glandular tissue, that is diagnostic for gynecomastia. You can pat them on the shoulder, tell them they're fine, and keep
Go
examining
on
your
their
breast.
way.
But you're on your way. There's no need for doing a biopsy. There's no need for an ultrasound. It's definitive. That's what the mammogram can do. But if you see something else, especially if you see something in one breast and not the other breast, then that should be worked up with an ultrasound and potentially a biopsy. So there is no screening test, but the first diagnostic test, other than seeing a doctor and having them examine you, is for them to order a diagnostic mammogram to look at the breast anatomy.
What is gyne? I'm not even trying to pronounce it.
What is
And how does it relate to
gynecomastia?
breast cancer?
Well, I think we've touched upon it several times, but it's important. So gynecomastia. So gynecomastia is male breast development. It naturally happens at 3 times in the lifespan of a male. It happens in infancy, like when they're born. Babies often have a little extra breast development. That's because they're carrying their mother's estrogen, so it stimulates the growth of the breast tissue in utero as well as initially after. Teenage boys often get gynecomastia because there's an imbalance in their estrogen and testosterone level until it stabilizes, and then the breasts usually regress. And then men in their 60s and 70s, they have some loss of testicular function. The testicles they make less estrogen because the testicles start to atrophy. Uh,
Estrogen or,
they make less testosterone.
okay, that's
Sorry.
what I thought.
Thank you. Sorry. Pardon me. They make less testosterone, and so they have a relative increase in their estrogen level because the estrogen doesn't drop, but the testosterone does drop, and they can get. And then, of course, people who put on a lot of weight. But these are sort of three natural physiologic time periods where one can expect to see growth of the breast. It usually happens in both, although it could be more on one side than the other. Gynecomastia tends to be or can be tender, and it's usually centered behind the nipple and goes a little bit up into the outer parts of. So anyway, that's gynecomastia, and the way that it relates to breast cancer is it's often, the things that give rise to gynecomastia outside of those three natural time points, uh, can increase the risk of breast cancer. Is often confused as breast cancer. We talked about how you can distinguish it from a mammogram. But if you have gynecomastia, since we know the things that can increase the risk of non-physiologic gynecomastia can also increase the risk of breast cancer, you should be attentive to screening.
I bet teenage boys just love going through that.
I think puberty is a challenge for both boys and girls in different, and for boys, it's definitely one of the challenging aspects of it.
Yeah. Should men get genetic testing? What would be the pros and cons of the testing?
Right. So genetic testing we've mentioned already, and but it's really important. Want to emphasize again, the most common reasons for genetic testing is if you have a family history of breast cancer, we say female breast cancer, um, particularly, triple negative breast cancer is a reason for testing. Breast cancer is diagnosed in premenopausal age is an indication for breast cancer. Ovarian can is an indication for genetic testing. Ovarian cancer diagnosis is an indication for genetic testing. That's the caveat. So we generally think of these as the indication
Right.
for testing
Women.
women, but it is an indication for testing anyone in that person's blood relative in that person's family, because the mutations are carried by both men and women equally. You get half your genes come from your dad, half your genes come from your mom, and they can equally be the source of a mutation. Although the mutation might not manifest in the men, they may pass it on to the kids. So if a woman is diagnosed with, say, any of these diagnoses that I gave, pancreatic cancer, ovarian cancer, breast cancer at young age, triple negative breast cancer, she should be tested, her sister should be tested, her brother should be tested, her mother and father should be tested.
Now that for all of breast cancers?
For these breast cancers that are associated with a high prevalence of mutations,
So
triple negative,
HER2 isn't one of them.
no, no.
Okay.
But I want to add to that list high-grade prostate cancer, right? So any man who has a diagnosis of high-grade prostate cancer, meaning prostate cancer that has spread to the bones, or man who has died from prostate cancer, then that individual should have been tested. And even if he weren't tested, his siblings should be tested because I mean if he
And
say
his children.
yeah, if he passed away and was not available for testing, then his blood relatives should consider testing because that might have been a manifestation of a BRCA2 mutation that was undiagnosed. So the point of this question is, should men get testing? Everyone should get tested who is in a risk group that suggests that the mutation might be present. And the cancers that are most associated with mutations are high-risk prostate cancer for men,
Okay.
pancreatic cancer, either sex, ovarian cancer, women, breast cancer, either sex, uh, triple negative breast cancers, whether it's male or female, and cancers that the two other categories, cancers that happen in people before the age of 60, sorry, before the age of 50, like premenopausal, or if there are multiple cancers in the family. So there's a lot of indications for genetic testing.
What about the hormonal cancers? ERPR.
Uh, no, we kind of at my office, we have a policy of testing everyone. Now that's because there are some things that those criteria that I just mentioned don't capture. There will be uncommon patients without those characteristics that are mutation positive. But if you're thinking only of the receptor status, the triple negatives are the ones that are most likely to be mutation related. And for many years, 10, 15 years, it's been the standard practice, at least it's been according to current guidelines, that people with triple negative breast cancer should undergo genetic testing. That has not been the case for ER positive or HER2 positive breast cancer.
Have you treated men with breast cancer? And if so, did you find their recovery time and side effects to treatments different from those of women?
So I have treated a number of men. I don't think anyone treats a lot of men, given,
No, I know.
I treat maybe 2 or 3 men a year, and three is a lot for me. So it's more like 1 to 2 a year. Um, I'm treating one currently with male breast cancer. And so uh, the recovery time largely depends upon how you treat it. We're going to talk about that more in a moment, but breast cancer treatment for women as for men includes, some sort of surgical management of the breast, some kind of medication, and possibly radiation as well. And so the type of surgery you do impacts the recovery and whether or not they need just anti-estrogen therapy or chemotherapy also impacts recovery. So the answer solely depends on how they're treated. Um, but in general, you
So
know,
basically it is the same as with women.
yeah, if you do the same thing,
Yeah,
in both sexes, the recovery time is likely similar. The main difference is that, many women consider breast reconstruction. That's not really a viable option for men. I mean, so the recovery time, if the mastectomy is done in a man, it's usually a definitive procedure with no reconstruction plan. For a woman who's having a mastectomy, the reconstruction might have several other phases
right.
to it that can extend the recovery time.
Is breast conserving surgery, lumpectomy, an option for men? Why or why not? And I'm going to throw into that also cryoablation.
Okay. Uh, so breast initially, when treatment was established for male breast cancer, the guidelines recommended only mastectomy. Uh, but and that was partly the reflection of the fact that mastectomy was the way we treated both cancers, not
Right.
I mean male as well as female breast cancer. So that wasn't really it wasn't really until the 90s that lumpectomy became an established option for either sex. The trials started earlier, but it wasn't really widely accepted before then. And so mastectomy was the only way to go. But based upon experiences from female breast cancer, and basically male breast cancer looks to female breast cancer for guidance regarding everything. Uh, Based upon success with offering females breast conservation, there was increased acceptance in offering males breast cancer, those that presented with early stage disease. So if the tumor was small enough, uh, say involving just the areola or an area near the areola or one part of the breast or another, but small enough that could be removed with just excision of the tumor with margins, with radiation added, then it at least there were no studies looking at this, but it was concluded that it would likely have the same outcome as
A
female breast
lumpectomy.
cancer. Right. So basically, the lumpectomy and radiation for males was emerged as an option because it was successful in women. And now the last statistics that I saw suggest that about 20% of men get an actual lumpectomy, uh, plus or minus radiation, if they're diagnosed with breast cancer, whereas many years ago that was maybe 1 or 2%. And then prior to that, no one really got it. So the acceptance is growing. Now, and that is the lumpectomy with radiation added to reduce the risk of recurrence in the remaining breast. That's kind of the current one of the current options which we consider standard. Now, cryoablation has also been something that has been used. I've used it to treat male breast cancers. There's some opportunities as well as challenges. The opportunity is that if the tumor is small enough and you can ablate it completely, then just like lumpectomy and radiotherapy, or you know, cryoablation can be a way of treating it short of removing the whole breast. One of the challenges is that male breast cancer often arises right under the areola, right next to the skin of the areola. And so there might not be much space between the tumor and the skin to enable a
Freezing.
straightforward, cryoablation. There are some workarounds, uh, but uh, for those that have, there's a tumor that's clearly separate of the nipple and skin, they can be a great candidate for cryoablation. Those that have skin involvement become more challenging candidates for cryoablation.
What are the pros and cons of breast serving conserving surgery versus mastectomy?
So there are a number of pros of breast conserving surgery. Number one, you can preserve the normal breast anatomy, at least better. Even if the nipple and areola has to be removed, you can at least preserve most of the breast contour. And as you know, many men have gynecomastia, so they may have, quite developed,
Right,
breasts, if you will. And if you remove one, it'll cause asymmetry, and that might be less optimal for
right.
them. So if you can remove only a portion of the affected breast, then you have better symmetry. Um, Obviously, it's a much simpler operation with much quicker recovery. Um, and there's less, physical limitations related to,
Less trauma too.
less trauma related to recovery because of the, shoulder stiffness and chest wall stiffness that initially is a part of the recovery from the mastectomy.
What about the well, we'll get to that later, I think.
But the problem is that often men are diagnosed later, and
Yeah.
they're not diagnosed with small tumors, but they're more likely to be diagnosed with a tumor that involves the skin or a tumor that involves the muscle. And so sometimes, for those more and more often for those patients, we have to do a mastectomy to remove the affected skin, to remove more of the gland, often to remove a portion of the muscle so that, we can clear the margin in that direction. And so it becomes a bigger operation. And again, I think you have a question about it, but for, just as for women, we do lymph node staging as well. And if people have advanced disease, they're more likely to have positive nodes that requires an X-ray node dissection. So it's a bigger operation all around, bigger breast operation, bigger node operation.
I think one thing that not even the women, some of the women don't even get is that just having a mastectomy is not going to prevent you from getting breast cancer. It can still come
Yeah,
back.
yeah, yeah,
It
yeah.
would be the same with men, right?
Right. So, it is largely a stage issue. So when breast cancer is of a higher stage, bigger tumor size, involvement of skin, involvement of multiple lymph nodes, then even if you remove the areas that look abnormal, there is a higher potential that there's some microscopic disease remaining in the skin or in the lymph node area that could be the source of recurrence. So for these patients with advanced stage disease, certainly for stage 3 disease, we recommend radiation even after mastectomy, just as for women, uh, to reduce the risk of recurrence. And with the addition of radiation, then the risk of recurrence is relatively low. Not zero, but it's relatively low. Certainly a lot lower than it would be had radiation not been added for that situation.
This treatment for male breast cancer often involves surgery. We just did that to remove the cancerous tissue as well as chemotherapy and radiation.
So let's revisit sort of the components. So for both sexes, it involves some kind of surgery,
Mhm.
whether it's mastectomy or lumpectomy, or
Or cryo.
possibly cryoablation. Uh, it typically involves some kind of radiation or can. If it's lumpectomy, commonly radiation is added. If it's mastectomy, radiation isn't necessarily added unless it's an advanced stage. And for both sexes, if it is advanced stage, then radiation would be added in those cases. There's lymph node surgery in both cases. Generally speaking, there are exceptions, but generally speaking, for male and females, we want to do some kind of lymph node evaluation or removal of abnormal lymph nodes. And then, so that's what we call the local therapy and the regional therapy. Local meaning breast, regional meaning lymph nodes. And then we have to think about the systemic therapy because any invasive cancer has opportunities to leave the breast, long before it's diagnosed. And so we have to worry about how can we kind of prevent those areas from growing in the liver or the bone or the brain or the lungs or wherever these cells may go. And so systemic therapy is something to consider. So, you know, since most of these cancers are estrogen receptor positive, anti-estrogen therapy is a mainstay for treating both male and female breast cancers. Um, Tamoxifen is the main one for men. Although aromatase inhibitors work better in postmenopausal women, the tamoxifen works better in men, and so that's the main one that we use for male breast cancer that's ER positive. But chemotherapy also might be needed because if it's an advanced stage tumor, then just as women can get chemotherapy, it would be advised to have chemotherapy as well. Men would also be advised. In fact, the recommendations for men are based upon the clinical trials performed in women.
The chemotherapy issue, really, you should try it before you have the surgery, right? Because otherwise, once you have the surgery, you don't know what works.
It depends. So there's some general principles. Um, it is clear that for an advanced HER2 positive or an advanced triple or a triple negative breast cancer, that giving chemotherapy up front allows you to monitor tumor response. So you can modify the drug therapy after surgery if you don't get a complete response. And so that's pretty much, I mean, that's a principle that's been established for female breast cancer. And based on clinical trials done in women. And we know that outcomes are better because we can fine tune the systemic therapy better based upon the response. It also shrinks the tumor down and sometimes allows you to do less extensive surgery of the breast and lymph nodes. So, but learning from, the experience in women, it seems reasonable to utilize that approach for males with advanced breast cancer as well. And so, again, there's no trial that has examined this particular question, but for a man with a HER2 positive breast cancer, say stage two or more, or triple negative breast cancer stage, one or more, often we would consider or could consider pre using chemotherapy prior to surgery to assess the response so that we can determine if they need to have any additional drug therapy or different drug therapy after
Because I
surgery.
mean, once the tumor is gone, there's no way to know for sure that a particular chemo is going to work.
That's right, but it's really, at least in terms of the clinical trials, the ones that are most meaningful are the ones that are focused on triple negative and HER2 positive. For hormone receptor positive therapy, there's no guidance or no, I mean, we do preoperative hormone therapy like anti-estrogen therapy to downstage, but there's no clear guidance that you know that you should change therapy based on response.
Well, with the hormone one, you know that you just have to stop the hormones or
or you can
lower
you
them.
can or you can
Yeah.
escalate them. You may actually give additional, but the trials didn't really look at the trials looking at preoperative anti-estrogen therapy showed that you can downstage tumors to make surgery better, but the survival didn't necessarily improve because of that. It was, you just made the surgery easier to perform because the tumors were smaller, the lymph nodes were smaller, but there wasn't a difference in survival. And there was also not another drug you can add, at least at the time. Now maybe those studies will be done in the future, but that's not where we are now. So generally speaking, we'll move forward with surgery. If the tumor only needs anti-estrogen therapy, then we can move forward with the surgery first. If the tumor is advanced and you're going to do the chemotherapy to downstage things, even if it's not triple negative or HER2 positive, then you can do that because it can make
Right.
tumors smaller. But it's not clear that that's going to allow you to change the drug therapy later. Anyway, that might be a little bit too complicated, but the point is that in
Yeah.
general, there are some cancers that clearly should be treated
Ahead of time.
ahead of time with drug therapy, with surgery to follow.
I just had another thought. When you do this surgery, like lymph node surgery, not lymph node, lumpectomy,
Mhm.
can men get interruptive radiotherapy?
Yes, we've done it. We've
Because
done it and we've
I did, it
published
just
it.
hadn't come up before. And
Yeah.
in my mind, if it had been me and I'd had a lumpectomy, that would be the best way to go. Because it's so targeted. It's not like when you get the regular radiation, you have no control where, not as much control where it goes.
Right. So that's a very good point. So, as you know, I've been doing intraoperative therapy for many years, and the idea behind intraoperative radiotherapy was to deliver the radiation dose as a single dose during surgery to eliminate the need
Right.
for several weeks of surgery of radiation after surgery. Now, it's only suitable for people with stage one or early stage two breast cancer, but that's a lot of people, and it's also some men who are diagnosed with breast cancer. So if they're a candidate for lumpectomy, uh, and they have early stage breast cancer, is certainly the standard practice in my practice to offer them intraoperative therapy as a way of reducing the risk of recurrence and also reducing the burden of radiation therapy. And I've published on that with some other people. We've kind of pooled the cases that we've because no one has enough cases to
To
publish
do
a
it for
lot.
one.
But we pooled the experience, and also have done the same for cryoablation as well. But in this question, yeah, intraoperative therapy is an option for early stage breast cancer in men.
And it's because the later stages, it has gone somewhere else and the interruptive can only do a certain space.
Right. Intraoperative is quite targeted. It doesn't treat the skin of the breast kind of intentionally, and it doesn't affect the lymph node area. It doesn't treat that area. So if you have disease that involves the skin, then the radiation should include
Right.
the skin. If there's disease that involves the lymph nodes, the radiation field, especially if it's multiple nodes, then the radiation field should include the lymph nodes. And the targeted dose that we give with intraoperative therapy doesn't have a wide enough scope to cover those areas
But it's an ideal solution if you can do it.
for the early stage, yes.
Do men have to have lymph nodes taken out? If so, would you advise a sentinel lymph node biopsy? Why or why not?
Okay. So let me just start by saying that, for many years, the removal of lymph nodes was a standard part of breast cancer surgery, regardless of this gender or sex. And but when you think of people who are diagnosed early, like they have early stage cancer, the cancer involves the breast, but there's no sign that involves lymph nodes, like the lymph nodes look normal by
Right.
ultrasound, they feel normal, then at least for women now, there's a lot of data that show that if they have early stage breast cancer, especially if it's estrogen sensitive, and they're willing to take anti-estrogen therapy, that there's no need to do any lymph node surgery at all. That the medication, even if there's a microscopic disease in the node, the medication
We'll take care of it.
will take care of it. And so for women over the age of 70 with stage 1 breast cancer willing to take anti-estrogen therapy, for 10 years, the rules have been they should not routinely be offered lymph node surgery. You may consider it, but you should feel confident that that you don't have to offer it. Although that's still not widely adopted, it's been clear that most women over 70 that met those criteria uh, don't need lymph node surgery. There's another recent trial showing even younger women with early stage breast cancer can
Don't need
avoid
it.
lymph node surgery, assuming their lymph nodes are normal at the beginning. Now, these studies have all been done in women. None of these studies have been done in men. So, we don't necessarily have guidance yet to say we can apply them to men, but at least it kind of is
It's a good
telling us that
indication.
we can be more nuanced, when we think of the patient, the tumor's characteristics, whether or not she's willing to take antitherapy, we can start to limit some of the things that we did routinely. Now, but at the current time, the standard is still to offer a man with normal looking lymph nodes a sentinel biopsy, just as we have done traditionally with women. That involves injecting a dye or radioactive substance in the breast. It flows from the breast to the lymph nodes, identifies the lymph node that drains the fluid from the breast, the first one or two lymph nodes. Those nodes are removed and sent to the lab for testing to see if cancer is present. That is still standard of care for male breast cancer. If they have abnormal lymph nodes, like we have a reason to believe that the lymph nodes are positive, or they've been a biopsy that shows a positive biopsy, then we would do lymph nodes dissection, taking out those nodes and some additional nodes as a standard. But would I advise sentinel biopsy? That is still the standard for men. I think there's a little bit more wiggle room. There's a lot more wiggle room to avoid it in women. Um, but maybe, when we look back at some data, we'll find some group of men who probably can avoid lymph node surgery as well.
When you do lymph node surgery, I know some people can end up with lymphedema. Does the number of lymph nodes you take out have a lot to do with how whether they get lymphedema or not?
It directly correlates with the risk of
So like if you
lymphedema.
do only the sentinel ones, you may not get it.
Right. In fact, the data show that the incidence of lymphedema after sentinel biopsy, say with 1 to 3 lymph nodes removed, is about 5%. And even then, it's usually mild. It's not like what you imagine lymphedema can be. And most of those patients have reversible lymphedema, as long as it's diagnosed and you intervene with certain measures early, because they haven't really lost much anatomy. The anatomy uh, that remains intact is sufficient to drain the arm of water and allow it to flow back towards the heart without having it back up in the arm, which is what lymphedema is. It's the congestion or retention of fluid in the arm
Right.
that can't flow back towards the heart because the passages, either the vessels or the lymph nodes that the water flows through, uh,
Aren't there anymore.
aren't there anymore, aren't working anymore, are blocked for one reason or another. So the less nodes you remove, the less risk of lymphedema. Also, the nodes that are closest to the breast, which are the ones that usually are the sentinel nodes, they're kind of in a safer area, but the ones that are higher up, they're a little bit more hazardous area, and you don't necessarily know where it is, or if you're going to cut through good ones while you're trying to get to the bad ones. But that's the take-home message related to your question is that the risk of lymphedema goes up as the lymph node number of nodes removed goes up. Um, so our goal with the sentinel biopsy is generally to take between 1 and 3 lymph nodes to minimize the harm. Most people have 20, 30, 40, 50 lymph nodes. We don't, everyone's unique, but I've certainly done operations where we've intentionally removed the lymph nodes because that's what we did back then. And we had like 52 lymph nodes in the sample,
Ooh,
which is, kind of crazy when you think of it, because that was the standard when I,
yeah, because I've
started
had
off.
some people with pretty bad looking lymphedema.
Yes.
Um, I thought I read one time on one of your websites that you had a procedure that you did with lymph nodes that lessened that.
Well, there are a couple of strategies that are available. The most employed strategy that I do now is simply not to do lymph node surgery. So I find these patients that meet the criteria for omitting lymph node surgery, and I don't offer lymph node surgery. There's nothing better you can do than simply not disturbing the anatomy in terms of preventing lymphedema. So that's the first thing now. The second thing is, often, lymph nodes are kind of hard to see, and certainly the blood vessels carrying that flow to and from the lymph nodes are really hard to see. So a very basic thing that I do, especially for people for whom I need to remove like more lymph nodes, like if their lymph nodes are positive, I need to do more extensive surgery, is we do something called axillary reverse mapping, where we inject the blue dye in the arm. The blue dye flows from the arm towards the heart, but it shows the lymphatics in the armpit area is blue. They turn
Mhm.
because the stain turn, and so at the very least, I'm able to avoid things that are blue that otherwise would be invisible. So this mapping technique allows me to avoid lymphatic vessels that I would rather preserve. That's a second uh, level of care. The third level of care is sometimes the lymph node that you need to remove is actually a lymph node that also drains the arm, that it drains both the breast and the
Okay.
arm. And you kind of have to remove it because either it's positive or you suspect it might be. And so there's a technique whereby we basically take the lymphatic vessel leading to the node and lymphatic vessel leading from the node and connected them.
Connected.
Right. You can either connect them tightly or connect them loosely, but either way, whether loosely connected or tightly connected, they usually reestablish flow. Um, and then finally, you know, we monitor patients pre and post-operatively. So practice is to do lymphedema screening before surgery. If I'm going to do lymph node surgery, like we'll figure out what their arm metrics are, like what the diameter is, how much water it has, and then do it after surgery and do it a couple more times. And if there's any indication that the volume is increasing, maybe that there's some lymphedema that's starting,
Mhm.
um, then the data show that if you intervene at that time with the use of a compression sleeve that you have them wear it for basically a month around the clock, that can actually stimulate the body to open up new pathways
Okay.
to get rid of the fluid. So you could actually kind of prevent the lymphedema by intervening early, but you have to do that early, otherwise the other pathways won't
Won't
won't respond,
step up.
won't step up, right?
Okay. Let's see. I know lymph nodes are involved in the cancer in both men and women. How much does estrogen or testosterone play in the role in the cancer's origin and metastasis?
So here we have we've addressed this to some degree, but the main point here is that male breast cancers, 70 to 80%, depending upon the population, are ER positive. And so uh, you have to sort of manage the estrogen level uh, to prevent its
Mhm.
recurrence. And and so we want to lower the estrogen level, uh, and we use anti-estrogen therapy to do that. Testosterone plays a role, but indirectly. If you take too much testosterone, it converts to estrogen, and then it can, or if you have prostate cancer and you're treating the prostate cancer by lowering the estrogen level, sorry, you're treating the prostate cancer by lowering the testosterone
Testosterone,
level, then it will cause the
estrogen to increase.
the estrogen to increase relatively, meaning you drop the testosterone, and so now the relationship between estrogen and testosterone favors the estrogen, and so that can then cause gynecomastia or potentially worse, a breast cancer. So the estrogen and testosterone play a central role in both. The testosterone doesn't directly cause it. It's just that testosterone is converted to estrogen.
Right.
The body tries to maintain this balance. So you put more on this side, it tends to spill over onto the other side. Put more testosterone in, it makes more estrogen because it's trying to maintain this
Nice
sense
balance.
balance, right?
The lymph nodes, is that the only way that the cancer can metastasize other places, or can it do it other ways?
Sadly, no. It can do it other ways. The cancer spread, the two predominant ways that breast cancer spreads is through the lymph nodes or directly through the blood vessels. Every tumor has a rich supply of blood
Right.
vessels. It's there from the earliest of days, from the cancer formation. And so there are opportunities for cancer cells to break away and go to other body parts. Now, the truth is, most breast cancers that break away, most breast cancer cells don't have the tools to set up and survive, like go to a place and set up camp and
Right.
grow. Uh, Fortunately, or the places where it grows it isn't suitable for it to set up camp and grow. But there is at least the opportunity, in theory, for cancer cells to leave and go to some places where they can thrive. And so the reason that we routinely offer systemic therapy, whether it's anti-estrogen therapy or chemotherapy or anti-HER2 therapy, the reason that we routinely offer it to people who don't have proof of spread is that we know that in the lifespan of that cancer's growth,
There might have been escapes,
there might have been,
escapees.
right, there are escapees, exactly. And so some people certainly will perceive it as overtreatment, and it is overtreatment for some people because we don't know who has escapees or who doesn't until the escapees kind of
Show
act
up.
up, right? So as a precaution, we routinely offer some kind of therapy to everyone with the goal of killing the escapees so that they never have a chance to grow. It's not a perfect solution. Certainly, it has its side effects, but we know that when we don't do the systemic therapy, there are more people that show up with cancer metastasis that spread than those that get it. So that's why, you know, kind of overtreat in a sense to prevent.
I wonder if
The
they can just do a lower dose
Well,
other than the full-on dose.
the doses are based on trials, and so that's kind of what we learn. Uh, it's a trial and error process. We start but I will share at least a couple of good things. Again, it's based on trials. Uh, we don't in order for you to make predictions or recommendations, it has to be based on a robust population of
Right.
patients, you know, control arms, so you can be definitive. Uh, so that's why we come up with standard doses that apply to everyone because that's the dose that was used in the trial. But at least for DCIS patients, I'm going to talk to DCIS patients now. Uh, there's the dose that we use for tamoxifen, for example, was the same dose that we use for invasive cancer. Sorry, let me restate that. For people with DCIS or stage 0 breast cancer, the dose of tamoxifen that we use for them was the same dose that we used for patients that had invasive cancer, uh, 20 milligrams a day. Uh, but there was a recent trial that published long-term results, a trial, so they had to test the
Right.
question, where they looked at use of low dose tamoxifen, like 5 milligrams a day, as opposed to 20 milligrams a day, and found that it was highly effective with relatively few side effects. Certainly not the more fearful side
Right.
effects from the higher dose tamoxifen. So, it's a long evolving process of trying to figure out the right solution for the various problems, and we don't want to like just be random in what we recommend. But the lower dose, choosing the lower dose kind of has to be the result of a trial looking at the lower dose before, as a community, we would say the lower dose is fine.
But there's still to do more trials in it too.
Yes.
Because I know there's one on Zolota that they did.
Mhm.
So hopefully,
So,
because I wrote a paper on the overdosing and dosing,
mhm,
because I went to the conference last year and I heard a lot of things about how they do clinical trials and how they come up with their dosing,
mhm.
and it didn't sound good to me. I didn't like
Well,
it.
yeah, as you learn, it's often like the maximum tolerable dose, right?
Yes.
Right. So to give them the most that they can give to get the most, in theory, benefit, but with the least harm, and you sort of escalate the dose until you find that the harm is not
And that's
acceptable,
the
and you
stage one of the
and you
trial.
stop there, right? Uh,
And then everybody gets that as a standard dose.
yes, that's that. That's kind of how it's done. Uh, and then you work back from there.
Right.
Uh, because, if you only did the lower dose, then the benefit of the lower dose, it'd be harder to see the benefit of the lower dose. So it takes longer to get to a drug solution because you're going from, say, small dose to slightly higher to slightly higher, slightly higher. It might take you 10 years to get to the dose that actually has any benefit,
Oh,
right? Uh, so not that that's a perfect solution, but the reverse is to start with a higher dose. So you at least demonstrate if there's a benefit, say at 3 years. And then if there is, you approve that dose. And then you work backwards to say, well, how about a 10% lower dose or a 20% lower dose or 30% lower dose?
so I
Well,
did the Zolota one
okay.
and I did 2/3.
Mhm.
So I did 30% less than the total.
Mhm.
And it actually worked out for me in 4 months, everything was cleared up.
Yes.
But my mistake was I should have stayed on it longer than I did, which I'm learning the hard way that sometimes you don't want to quit for a while because my lungs got some back, but my liver's been perfect. So it had its ups and downs.
Well, with everything, we live and learn, and hopefully we live longer so we can learn more.
Well, I look back at when I
Yes.
did the Herceptin and only did 6 months, and I wonder sometimes, well, if I'd have done a whole year, would have I ever had the metastasis problem? But you can't, it's water under the bridge. So
Exactly.
I know lymph nodes are, oh, we got that one. What's going down here? Does your practice provide patients who have had mastectomies any type of garment after surgery to go home with?
Yes, that's an interesting question for this topic, but it is relevant since men often have mastectomies when they have there are three things that we commonly offer to patients or utilize. One is that I use a
Binder?
tube top binder to hold compression on the wound because ultimately you're trying to get the layers to stick together. So certainly we put in the drain to suck out fluid between the layers, but by using the binder, we can hold pressure and discourage fluid formation as well while encouraging the drainage of the fluid. That's one.
But
Uh,
even with cryoablation, in that case, you wear a sports bra because you want it
right,
to be tight too as well.
it's a different
Just
kind of
not as tight.
yeah, and the main difference here is that they both are about managing fluid, but in coagulation, there are no cavities we create. With surgery, there's a huge cavity. Mastectomy, there's a huge cavity we create. And the walls of the cavity we want to stick together, to facilitate healing. So the binder helps that, as does the drain. So that's one thing. The second thing is, there's a drain belt or drain holder, just something to help keep up with the drain. Is another tool that we offer. And then the third for patients who would like to shower early after surgery, there's a shower cape, which is a kind of a cape that goes around the neck and it seals around the neck. It comes down to about below the rib cage and has pockets for the drain so that if someone wants to shower, even the day of surgery or the day after surgery, they can they can do so and clean their lower bodies, wash their hair, and feel better about themselves. And for some people, especially women who have mastectomy and maybe reconstruction, sometimes they have to go a week or more without showering, depending upon what kind of bandage they have. So this eliminates that issue of delaying surgery to protect the wounds.
You mean delaying showers?
I'm sorry. Sometimes I'm like two
You get
questions
ahead of
beyond.
yourself.
Yes, this avoids the question of delaying showering to allow for protection of the wounds at the surgery. You can do both with a shower cape.
I had drains from a surgery once. They were no fun. But my sister-in-law gave me a great idea. I actually got a fanny pack and put them in a fanny pack.
Yes, yes.
I mean, you can't
At
get
least
rid of them. You're stuck with them for a
you
while.
were able to keep up with them better that way.
Yeah.
Yes. So there are various solutions for that now, but that's the answer to the question, I think.
Oh, we got lots of time left over.
Did we finish the questions?
Yeah, the only other thing I had was the one, what I said in the beginning, where my friend Leah
Okay.
lost her
Uh,
husband from breast cancer. And that's a tough one because I think somebody else texted me and said they lost somebody too as well. Because they don't think that you can get it.
Yeah, so the irony is that stage for stage, like comparing stage one in male breast cancer to stage one breast cancer in women, or stage two, comparing it between the two sexes, the survival is about the same. The problem is that more men are diagnosed with advanced
Yeah, because they don't look
cancer.
for it. They don't know that they can get
Right.
it.
And so they're more likely, so that's one issue. There's also an issue of there being that, although tamoxifen, affects everyone, men tend to have more side effects from the tamoxifen. And so most studies show that their compliance rate is relatively low. They start off, but relatively fewer are taking them after a few years. And so obviously it's being given to treat the escapees so that they don't grow. But if you don't take it, then there's no treatment directed to metastatic cancer.
There again, you're back to the dosing. What if you gave them a lower dose? They might be more likely to take it, and hopefully it would still work.
You know that I mean
It's
it's something a decision you can make on an individual patient basis, and certainly I often negotiate with patients in that way. But there's
don't I
no
know?
but without doing the trial, you can't say what the lower dose will be. I'll give you a couple of ways that I negotiate with patients. Uh, obviously, when I won't say obviously, a lot of people fear like the effect of the medication when you start it. So for patients that are really reluctant, I first start by saying, just give it a try.
Mhm.
If it if you find that it's intolerable, you at least you have an individual personal reason to stop. Like it's not working for you. It's not like what happens to other people. Most in most cases you hear the squeaky wheels make the noise. Most people are doing quite fine on medication you don't hear from. And in fact, most people are doing quite fine on tamoxifen and the aromatase inhibitors, and they're not complaining, so you don't hear about them. You hear about the people who are complaining. And in my experience, about 80% of the people taking these medications have minimal side effects with no significant impact on their quality of life. They're able to take it for the duration. The 20% have issues and they can't, but you don't know which
You
one you're
don't know
going to
till
be
you
in,
try it.
and likely going to be in the 80%. And you don't have to wait 5 years to make a decision. You can make a decision in 1 month or 2 months if it's intolerable for you. So the first thing is just give it a try. The odds are in your favor. The second is if you're concerned about like the punch of having a new drug and the side effects, to escalate it over like titrate yourself up. Like if it's to be taken every day for like because the daily medication like tamoxifen, maybe take 1 dose the first week, 2 doses the second week, 3 doses the third week, 4 doses the fourth week. To
You
touch
find out how you tolerate it.
yeah, at least just like it's like getting in you can take a big plunge, you can ease into the water really slowly in a sense. So it's like easing in so that you don't have any dramatic effect. So that's a way that you can sort of uh, you know, introduce something that someone is reluctant to try. And if you can get to the 7 days of dosing without any symptom, then you're golden.
Good.
If you find that you can do four, but the fifth and sixth, it's more than you can handle, then maybe that's a situation where you just do 4 a week.
Well,
I mean,
anything's better than nothing.
right, right. And even though we haven't studied that, you can deduce that because they're indirect evidence that taking a lower dose is better than taking no dose, even if it's not as good as taking the full dose. So that's a way that you can negotiate. And so even though these aren't trials, ultimately it comes down to finding a path for a patient to move forward, and that is one way that you can do that.
One of the things that I think is really important, and it would apply to men as well as women, is I'm always telling them to research whatever it is they have, learn as much as you can about it, then turn around and research all the medications for it and learn as much as you can about them. So then when you go to an oncologist, you're educated.
Mhm.
You can actually converse with them and not necessarily just take the first thing they offer.
Yeah, you can negotiate. Yes.
Yeah,
So
because like I did that with when I went metastatic and they wanted to do, Taxotere, Taxol, the typical stuff. I was like, no, I don't want to do those.
Mhm.
So I ended up doing Zolota, but I when I got the prescription and it said 3 twice a day, I was like, no, I don't want to take 3 twice a day because I knew what the side effects
Yeah.
could be.
Yes, yes.
So we finally agreed on 2 twice a day, and it worked great for me. 4 months and it was gone. I've been to seminars where I've met people that their doctors have them on the full-on dose, which I mean, even more than what my dose was. Like mine was what, six, 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 each one's 500. So that would be 3,000 a day.
Mhm.
I've met people that were on 4 or 5.
Wow.
They have blisters, they have horrible side effects. And so that's why I think we should all research what we do before we get it.
Right. I think, every decision is a trade-off. I mean, a trade-off between, you know, sometimes two different evils. You want to,
Right,
you're trying to avoid the worst outcome, so you take a less worse outcome. Uh, you also have to factor in what is the stage of the disease. Some disease it leaves more room to negotiate because the harm of it progressing is less. The disease leaves less room to negotiate because they may have advanced disease that doesn't lend itself to more modest approach. On the other hand, obviously, this is all patient-centered, so
right.
we have to respect the patient who wants to say, I realize that the worst outcome is possible if I take a lower dose,
Well,
but I'm okay with that.
my agreement was if it doesn't, you'd get scans every 3 months. If it's not working, then we'll up it.
So,
I
yes.
mean, I wasn't against that, just like this time around I have some spots that came in my lungs. And I knew what I wanted to take. So the agreement was that I would do what I wanted to do, Lizaloda again. But if it didn't get better, that we do a biopsy. And I was like, okay, that was fine. Because if it
Mhm.
didn't get better, I wanted to know what it is.
Right.
And the relief was to find out it's the same thing, but I'm probably not going to be able to stay on Lizaloda. I'm probably going to have to do something else. So it's kind of, that's why I say that you need to know as much as you can about the disease and as much as you can about the treatment. Because then you can kind of negotiate or at least somewhat control what happens.
Mhm.
And, it's all a learning experience on everybody's side.
Yes.
That's why it's called the practice of medicine, not black and white.
Yes, right. That's right. So I think we have a guest still here, right?
Yeah, she's right here,
Okay.
Sherry
Okay.
Ambrose.
And so we want to introduce her. We're going to let her into the room, I think, if I can figure out how to do this.
Well, Sherry has a advocacy program for men with breast cancer. It's I know what it is.
Oh, can you hear Sherry?
Yes, I can.
Okay, why don't you share what your patient advocate 501 is?
We are the Male Breast Cancer Global Alliance. We are a 15-year-old nonprofit 501(c)(3) with a global reach who are here to support men diagnosed with breast cancer around the world. We advocate on their behalf with researchers, pharmaceutical companies, and the government for inclusion and a seat at the table. We educate people to the risks that they face or their families face to a diagnosis of breast cancer as a male. And we are also currently involved in supporting and helping to fund research efforts that are specific to men with breast cancer.
Thank you. Are there any ongoing trials for male breast cancer that you might want to share with us?
There absolutely are. There's a study right now out of Dana-Farber known as the Ethan trial. It is a phase 2 study of the endocrine therapy for male breast cancer and its efficacy. They're looking at various uses of endocrine therapy regimens. And what they're doing is doing this on men who are just being diagnosed prior to surgery. They enter the Ethan trial. It's available right now in 6 large sites across the country. We're actually hoping to fund 2 additional sites to open. And they follow the men with the chemo and the endocrine therapy prior to surgery. Then once they have the surgery, this is actually giving them the answers to Sharon's question of trying chemo prior or the endocrine therapy prior to see what works better. So it's actually giving men options where they didn't have them before. There's also another
Not restricted to a certain stage, like stage 3 or stage 2. Does it matter? The
no,
trial? Okay, great.
no stage. The other study, it is in its forming stages, will be a 4-year study out of Vanderbilt University, taken on by Dr. Ben Park, that is looking specifically at breast cancer in men. So I don't have any further, I have the whole write-up on it, which I can gladly share with you at some point, but right now that is not underway yet, but Ethan is.
Okay. Yeah, when you have it, share it with Sharon. I'm sure she'll make sure it gets out there into the world.
Yeah,
Is the Ethan one still recruiting or is it closed?
absolutely. Yes, it's recruiting. I can also send you all that info. I know I was looking at it earlier today because I have to post it back on social media again.
And are there any important parts of the story that we've missed? I'm sure there are. So
Um,
what would you like
Well,
to?
one of the things that I'd like to mention, and it's sad because I've actually tried to work with many of the breast cancer organizations, specifically the ones for women of color, to understand that their partners and the men in their lives have a 52% higher risk rate for breast cancer over white men.
Yes.
So their men actually have the potential to die at higher rates. And yeah, we're just trying to make all of that awareness out there. So I need the help of all the advocacy organizations to do this. I'm only one voice. I'm a large voice. Anybody who knows me, but it's hard to do it on your own.
Well, back to that initial question, the importance of putting the word out and collaborating. Obviously, using this as a medium, but working with advocacy organizations, they need to make sure that this remains as a part of the story. You mentioned, that all studies show that, the the certainly the prognosis is worse in African American men.
Hmm.
The incidence is also higher as well, and that also runs the statistics regarding prostate cancer are the same. So even if you're not sort of advocating around breast cancer, the advocacy around prostate cancer should also include this tie-in with breast cancer risk and the importance of, testing and being proactive. Thinking
Exactly.
risk of breast
Yeah.
cancer.
Now, was it your site that I saw there was a card that listed what you should do is to check for it?
Yes, we have a male breast cancer self-exam card. It's available on our website. I think right now in about between 7 and 9 languages. It's downloadable. It's something that can be mailed out anywhere around the world in English and Spanish. One side of the card shows an image of a cartoon type figure, not a man, doing a self-exam and telling you what to do. The other side shows you the signs to look for and potential risk factors.
Any risk factors that I missed in my summary,
Um, Not that I know
or
of.
ones that you might want to
You
reemphasize?
you did it. No, you did a great job. Let me see. I can actually look at the back of it. Oh, any prior treatment for radiation to the breast or chest area.
Yes, right. That's certainly part of
Um,
the guidelines for female breast cancer, if you will, treatment, particularly for Hodgkin's lymphoma to the chest. We call that mantle radiation and increase the risk of breast cancer
What
in
about
women,
thyroid?
and but also as thyroid as well. I mean, radiation with thyroid?
Yeah, because
Yeah, increase
it's
the
in
risk
the,
of thyroid. Yeah,
yeah.
it increases the risk of
Well,
thyroid cancer.
but does it increase the risk of breast cancer since the radiation may overlap? I don't know
I don't have
that much
data
about
on
it.
that. Do know about
I don't know too much about
for
it.
the treatment of the mediastinal nodes for the chest nodes for lymphoma does expose the breast to higher doses of radiation. Primarily, it's most important for women between the age of 10 and 30, those that get radiation when the breast is developing uh,
Mhm.
have the highest risk. So that's one of the indications for annual screening MRI, in fact.
Yeah. I do notice that actually when they talk about the disease being 1%, um, it to me, from looking at the statistics since 2008 when they were 1990 a year, we're at 2,800 potential cases a year, um, with over 500 men passing from the disease every year. To me, the number of men that I've seen coming forward in these past 15 years, it's higher than 1%. But sadly, because of the fact that they don't talk about it or they're presenting at later stages, it's something that when I spoke to the American Cancer Society, obviously, if a man is going in because he's having like liver problems, never realized he had breast cancer and
Mhm.
it metastasized,
Mhm.
they're not going back to the origin of the cancer unless the person was admitted and treated for a previous cancer in another area. So that person is ticked off when he passes away in the hospital, sadly, as a liver patient, liver cancer
Yeah, I
patient.
guess that could confound the statistics of it.
So I think our numbers are definitely skewed. I'm not trying to say like we're at 20 and 30 and 40%, but the numbers are definitely higher in men. I'm very grateful the fact that they consider it a rare disease, but at the end of the day, we do have treatment for the men, based on the treatment for women, that they have it available to them. But to go to your discussion on tamoxifen, yeah, the dropout rate is 45%. They just can't handle the side effects. And sadly, most of the physicians, and I totally get this, you guys are underpaid and overworked and doing the best you can. But when you have a patient in front of you and you're giving them something like tamoxifen or telling them, this is what you're going to have to take, these are your potential side effects. Or give them something that they're looking at, going to Sharon's discussion. It's not always where that patient is going to be thinking on the top of their head, oh, let me go and research this. They're just told to take it. So
Mhm.
they start taking it. And then, men aren't expecting hot flashes and mood swings. They don't get moody.
So they think.
Oh.
So they, in a different way, in a different way. Yeah.
So yeah, you did you hit on a lot of key points. I also like the fact that you talked about the bodybuilding supplements because sadly, the age of the men that have come in focus lately, average age is between 35 and 50 when they're presenting with their first signs of breast cancer. The youngest man we have on record was 18, was diagnosed when he was going into the military and he had his physical. He is thankfully a 56 year survivor and still on this earth, but had it not been caught, that would have been a totally different story.
Yes. It's amazing.
So, yeah.
Do the male patients also know that there's a lot of resources out there for funding if they need, if their income is, because sometimes if you end up with cancer, you can't work anymore or something. There's like all kinds of funds out there, like the PAN Foundation, the PATH Foundation.
Um, a lot of them, if they have not come to my attention, I don't know if the men individually know about it, but I certainly would be happy if you could connect me to them because what we do is we have the resources on our website. It's not something that we don't want to be an end all be all and do everything, but we do want to give them the best advice and resources and tools to get them through this diagnosis.
Well, I'll send you a list of the ones that I've been using. Also, a lot of times, like I know with one of the women I know, they give you the um, anti-hormone treatment and it's super expensive. Some of the companies will actually give it to you free, but you have to research it and put in an application.
I do have connections with most of the major pharmas. I know that became evident to us when before Ibrance was approved by the FDA. I think we were one of the ones that screamed at Pfizer and said, "Our men need this drug," and they're being denied. This is years ago, and they actually would send it to them directly without cost. So they are very good like that.
And some of the income levels that you have to be below are not really that bad because I think some of them they go anywhere from 300 to 400 to 500% of the poverty level. 500% of the poverty level is getting pretty up there.
Yeah. Yeah, no, definitely send me that information. I'd be grateful for it.
Well, thank you. Any other comments
Not that
about
I can
about
think
the
of
topic?
offhand. But oh, you should post in the chat your website.
I can do that.
We'll include it in the posting when we put up the post this to YouTube. We'll include
Thank you.
your organization.
And I think you have a Facebook group too, don't you?
We have a couple of Facebook groups. We have a Facebook group, a private page for men to go on, and I do keep an eye on that. In fact, I think Sharon, you got in there, but I booted you out.
Yeah, I
It
think
is
so. But all
it
I
is
wanted to do was post the webinar, so
I put it up. I put it
yeah,
on
so it
social.
got there. A lot of them that I went to, and I didn't even bother trying to get in. I just looked for who the administrators were and sent them the link and said, "Can you post this?"
Yeah. We try to keep it as closed as possible to give the men the ability to have
Oh,
these,
yeah, it was.
conversations. I know Rod's got his hand raised. He's actually the president of our board.
Yes, I would we can there are a couple of questions pending. We actually don't usually have it open to
Yeah,
the
but we're done
but
early.
but we can make this exception now since we can't always control what comes in, so we try to manage it. But
Well, and if I
Rod,
do the questions ahead of time, we usually have more
Uh,
time to get more out there.
mo-
Rod, you have the
Hi,
floor.
hi, morning. Can you hear me?
Yeah.
Yes. Okay.
Okay, all right. Beaming in from Australia.
Oh, nice.
It's
Welcome.
Sunday morning here. Sorry, I'm a bit late to the party, but I work with Cherie. I'm the president of the board of directors of the Male Breast Cancer Global Alliance. It's great that you guys have come in on this, and we could certainly do a lot of conjunction efforts. Really, that's really my main message. But I'm a breast cancer and a prostate cancer survivor. 10 years for the breast and 8 for the prostate. Quite an active advocate.
Any linkage for you in terms of mutation, if you don't mind saying?
Yeah, that's a good question. VUS, variation of unknown significance. But really, you sort of got to give away where it came from and just deal with what you've got.
Yes.
To be fair, but there is a lot more activity in this male breast cancer space, and it's great. And men have for years been somewhat stigmatized, as you'd be all well aware, and they don't speak up. We have to hunt the people down, basically. They want to get treated and go away and just pretend they didn't have it. And I get that as well. I think that's excellent. Everybody has their own ways of dealing with it, but Cherie and I are keen to make it less of a stigma, if that's possible, to normalize it and to bring lots of guys out there to meet each other and to help each other through treatment and anything that might happen post treatment. So that's really where I'm at.
That's obviously that's very important, making it less of a private sort of area of shame and engaging people to share their stories does kind of make it more acceptable. It certainly has worked for female
Women.
breast cancer, certainly. And so bringing men literally out of the closet to talk about, their own experience will make it easier for others to share theirs as well.
Well, and I think it's helpful when you have friends that are going through the same thing. You can encourage each other. And my other half of when I say no, knowledge is power, I also say attitude is everything.
Yeah,
So
I like that.
it, how we act can help how somebody else acts. Plus, the more negative you are, I think the faster you go. I think being positive and trying to just enjoy your life, might as well enjoy it.
Yep, perfect. Well, thank you very much.
Uh, well, thank you as well. And so we have a few minutes to do other things. But I thank you for joining me here today and for suggesting this topic and for organizing the questions
Well, I'm fighting my own, so.
and leading
Thank
at the
you
same.
both.
Thank
Thank
you.
you both. It was a great presentation.
We normally would do this every other month, so we'll get
Right.
back on the every other month schedule.
At least try,
We'll
yeah.
try, we'll try. And so
It's the other schedules, like when I'm not available or he's not available, he's awfully busy.
but we're here today, so thank you. So I'll leave it to you also to probe your associates for a topic for the next
Okay.
conversation, and then we'll post it. Okay. Thank you again. Once again, I'm sorry. We'll post this recording by the end of the weekend, so it'll be available to you through YouTube and We'll put it out
We got
there.
another question.
I'm sorry, there's a
Are there any
a
tests
parting
that
question.
Are there any tests that you know of that would give an indication which endocrine therapy and how much would be good for an individual? Which medication takes care of the microscopic cells in the lymph nodes?
So it's an endocrine therapy question. Whether there have been a number of studies looking at there are basically two categories of endocrine therapy available. One is the tamoxifen-like therapies, which we call SERMs, or the aromatase inhibitors like Arimidex and those kinds of medications. Those are two main classes of therapy for early stage ER-positive breast cancer. And the studies show consistently that the tamoxifen is better for male breast cancer. For female breast cancer, the aromatase inhibitors are better for postmenopausal female breast cancer. For premenopausal female breast cancer, it's tamoxifen. So for men and for premenopausal women, the standard therapy is tamoxifen. And it's generally given for a 5-year course for those who can take it, or longer if you have advanced stage breast cancer, they may extend the therapy longer.
So it's also used for metastatic.
Yes, although it's not the first line for
Well,
metastatic,
yeah.
but it can be used for metastatic. The question is, why tamoxifen for men versus because there's a potential for the aromatase inhibitors uh, to actually increase the estrogen level in men, which is why the studies show when they compare the two that there was, I think I read a story that looked at the survival impact of AI versus tamoxifen in men, and for men it was 20% lower. And so the goal of taking the aromatase inhibitor in general for women is to block the conversion of testosterone to estrogen. For some reason, the effect in men seems to potentially raise the estrogen level. At least that was my interpretation of the data. That's how they explained it. You may need to fact check that, but that was my interpretation of the data. And for that reason, it produced an inferior result to tamoxifen, which does not raise the estrogen level. It simply blocks where estrogen attaches to breast cells and other cells.
I think on the other hand, women don't realize that they even have testosterone or need it.
We all have testosterone, we all have estrogen.
Yep.
And sometimes we have the wrong balance, or we need to change the balance for certain circumstances. And that's what the medications aim to do here. So it was, the data are a little less clear. I didn't read the sources of the publications, but the take-home message, the summary of the publications was that when comparing tamoxifen to AI, the tamoxifen was superior. And so tamoxifen is first-line therapy, and for people that progress on tamoxifen, then they will add the AI if the tamoxifen is insufficient as a standalone therapy. Obviously, there are other things to add now that are more recent, like the CD4/6 inhibitors, but that based upon studies done over, say, the last 10 to 15 years, looking at male breast cancers, the data showed tamoxifen to be better with AI as a supplement if there's progression. But again, there are newer medications now for ER-positive tumors. Not necessarily well studied in men, but apparently they are being studied in men now. And so we'll be able to see if there are better solutions going forward. Did you want to add anything to this, Sherry, since you are familiar with this study that's in the works?
The Ethan study?
Yes.
The only thing I was going to ask you directly is, would you be open to speaking to the gentleman who's running this out of Dana-Farber to see if this could be something that could be brought into one of your larger cancer centers? I know you're out in California, correct?
Yes.
He's
Well,
laughing at me.
I'm happy to speak to him, but this is not necessarily an area of expertise.
I gotcha.
I'm a
Okay.
breast cancer surgeon, so obviously I treat the range of conditions and I see a few patients a year, but I don't want to leave the audience with the impression that I am an authority on this. I've certainly studied, I've applied novel techniques like intraoperative therapy and cryoablation to extend to men the option of these less invasive treatment solutions.
Mhm.
But it's kind of hard to be an authority on this particular topic.
Got it.
And I'm authority on a few other topics, just not this one.
Well, thank you. The fact that you even
Yeah.
treat men or that you understand the disease and we're able to have this this wonderful presentation is a plus.
Thank you.
Kudos.
Well, I think we're now over our 1:30 timeline, and so thank you for
Sharon.
helping to bring it to a strong finish. Uh, we'll make it available to you soon. Thank you so much for your time, and see you next time.
Thank you.
Thank you. Thank you very much.
Bye-bye.
Whoops.